Thank you very much for your nice introduction. So just come back again. So, because this is a very topic issue. So for today, for the workshop, I just would like not just brief summary for you, but I just would like to get the comment back from the stage as well. If we can share from each country, so how far we go for the latent TB treatment. Okay, so I just would like to start with the first case. 42-year-old man on tenofovir FTC ripurin for 4 years. His current CD4 is quite high and with the viral suppressed. He came to the clinic because he was much worried about his partner. His partner was diagnosed with AB smear positive just 2 days ago. So they stay together not 24 hours, maybe 6 hours a day. And when he came to the clinic, his trace rate was normal. So what would you manage for this case? How to? Just vote, please. Okay, so you're going to do tuberculin skin test, IGRA, nothing, and also the latent TB infection treatment if positive TSG. So I will introduce you what should we do in this case, and actually this is like a missing message for our patient. So every time the patient comes, we should ask them not just the full symptom screening, but you should ask them about the contact case as well. Because as I showed you this morning that, so this region, we have such a high prevalence of TB, okay? So I don't know which one is the right answer, so just listen to me and then we will be back to the question. So if I ask you, does anyone who is exposed to TB become infected and get sick? Is everyone? No, right? Because when you look at this schema, so after exposure, about 30% of them get infected. So we call latent TB infection. And from 30%, about 5% of them had early progression. So we call recent TB in less than 2 years. So they have active TB in the first 1 to 2 years after exposure. Another 5 to 10%, they have late progression. It means that they have reactivation about 10% for their lifetime, okay? So, but in some population, so the risk of active TB is increasing. For example, in HIV-infected patients. So, in summary of this schema is that, so about 1 in 10 of patients, they will develop TB after exposed to TB bacteria. So how we know that the patient have just latent TB or the patient have active disease? If you look at this is so after infection, right, and the body can control the bacteria. So then the patient will get infected. We call latent TB infection. Compared to latent TB, in some time point, the patient will develop active TB. So it's about 1 in 10 patients will develop TB later. When you compare between latent TB and active case, so if you look at TST and IGRA, it's all positive. So it cannot distinguish between active TB or latent TB by these two tests. So you have to do like other tests, for example, culture and smear is positive. It may be positive for active case, but for latent TB, so it's asymptomatic, totally asymptomatic, so no symptom, no AFB smear positive, and also for the treatment we call preventive therapy. It's like a treatment as a prevention, and with the active TB, it requires multiple drug, multiple dose compared to latent TB infection. So just summary here that for the latent TB, so we have the TB bacteria in the lung, but it's just quiet. It's not. It is inactive. It's not active at that time. So, and then the patient usually they don't get sick from this and cannot spread the bacteria to other. And anyway, it can develop TB later on. So for TB disease, we have, so it's like we wake up. So it is bacteria is waking up for it's like reactivation and make person feel sick and have symptoms. So it can spread the bacteria to other. So if untreated, about 50% of the patient will die in 5 years. So what we gonna do for this case? So you have to identify the risk of patient that lead to development of active TB. So we classify the patient to 2 groups. The first thing you have to think about the higher risk of reactivation. The second group is about the clinical condition, increased the risk of progression. So I can show you here. So the risk based on TB exposure, close contact with an infectious TB case. You can see that it's very high, 16 to 46 times. And also immigrant from other from high risk country, and chest X-ray abnormal. So in my practice, I have seen many cases presented with chest X-ray abnormal, just like OTB. But when we ask them, they say no, they haven't been treated for TB disease. For this group, it's high risk of reactivation. And for HIV, it's 80 to 100 times higher for reactivation. And we miss some group, especially chronic kidney disease on dialysis. So for this group, it's not just high risk of reactivation, but it's also high risk of mortality. And also another important is the treatment is very complex. Like the Professor Saisophine just told you, if the patient have kidney disease, so it's also affect to the treatment. So how we know that the patient have latent TB? So we have 2 methods right now. One, you can do twin skin test. The another one is using interferon gamma release assays. Just remind you that these 2 tests do not exclude LTBI or TB disease. So anyone here has an experience with the TST? Yes, right? You do it yourself or you do it for others? And everyone already test for TST, right? So as we are healthcare worker, so at the first time that you work for the hospital, TST or IGRA should be done. Then if it's negative, it should be followed up in the next following year. So if it's turning to positive, it means that you just got TB infection. You have high risk of active tuberculosis develop within 1 to 2 years. So in that case, you need to get LTBI treatment to prevent yourself and also to prevent the patient and other healthcare personnel as well. So this is the right way to do. Just put it in the forearms and also produce wheel 6 to 10 millimeter in diameter here, right here. And also the patient can return to the clinic not early than 2 days. So it needs to be after 48 weeks, but it can last until 7 days. So but the best is 48 to 72 hours. So non-HIV, you should measure as a millimeter. But for HIV, as we interpret that, if it's more than 5 millimeter, so it's positive. So I just show you that for the HIV positive. So maybe you don't need the patient to come back to be read because you can teach the patient how to read it. Just put 5 millimeter here and ask the patient to look at the view, the nodule here. And if it's more than 5 millimeter, just ask the patient to come back because they should get LTBI treatment if no active TB is not found. So this is just an interpretation here about the HIV positive. We use 5 millimeter or greater, but for healthcare personnel, we use 10 millimeter or greater. For the interferon gamma release assays here, so the sensitivity about 70 to 94%, and the specificity is quite high, 88 to 99%. But anyway, it cannot distinguish latent TB from active TB, and it can cause like a technical error as well. So what the test that you want to use? If we can choose, we want the best test, right? When the WHO look at meta-analysis, either TST or IGRA, so the finding is it was not different. So why they recommend that? You can use either TST or IGRA, but in HIV-infected patients, maybe you don't need to test that because HIV-infected patients, they require latent TB treatment. And not just HIV-infected patients, the children younger than 5 years of age as well. So this is a recommendation for contact case. So any household and close contact, when the index case have this condition, for example, has sputum positive, multi-drug resistant TB, HIV, or children less than 5 years of age, you have to do contact case investigation. How the duration we use a close contact, it means that just 3 months prior the treatment, not count from the symptom, just count from the treatment, the TB treatment, okay? So within 3 months of TB treatment, so all the patients who have this condition should be investigated. And another recommendation is that the HIV-infected patients who are household or close contact of people with TB, and also after appropriate evaluation that they don't have active TB, should be treated for presumptive LTBI. So for this case, so we can answer that. For this case, he doesn't need the test. So if chest X-ray normal, if no symptom, so you just prescribe LTBI treatment. And also for the children as well, so it's very strong recommendation that if close contact, so they should get treatment. So this is just the algorithm to look at the patient who have HIV. You can see that for the HIV-infected patient, the test for latent TB is not required for this algorithm. So you just look at whether the patient have symptom or not, and investigate if he has a abnormal chest X-ray. If no any cause, so LTBI should be provided. This is contrast to HIV negative household contact and children older than 5 years of age, because the test is required. Because I said that it's just only 30% of the patient get infection. Not all patients get infection. For the case number 2, just a 28 years old male, MSM, very late presenter, and also just would like to ask you whether you would like to give LTBI and cotrimoxazole for this case. A, cotrimoxazole only. B, cotrimoxazole and LTBI therapy. C, nothing, only ALT. So what you want to choose? Wow, I think so. Okay, so many of you choose the cotrimoxazole and LTBI therapy. This is very good, actually. But again, B and A is not much too different. So you still reluctant to give the patient LTBI treatment, right? From this answer. This is the data from WHO report for the report in 2018. I was surprising that the Thailand is about 54% of them presented with the late presenter. So how we define the late presenter? So all adult patients presented with CD4 less than 200, so we call the late presenter. You can see this, but some countries, they do very good. And also, it's not, so Thailand, Indonesia, so we have many patients came to the clinic at the very late presenter. So this is a definition of late presenter. So it means that adult patient came to the clinic with a threshold stage 3 or 4 or CD4 less than 200, but for children younger than 5 years of age, with HIV are considered as having advanced HIV. So as Professor Sisopin already mentioned, so I just skip this. So they recommend to have a package for advanced patients. One of that package is about TB preventive therapy. You can see yes for all, for adult, adolescent, and children. This is a very strong message. Apart from cotrimoxazole, so LTBI is another package. So this, you need to screen, treatment, and or prophylaxis for major opportunistic infection, plus rapid ART for everyone. So just this morning, I showed you that ART can reduce TB disease, and LTBI add up another 35%, and also it can, the death rate can be reduced by 40 to 50%. This is very strong recommendation. I think for people living with HIV, it's no question on that. So just like to ask you, your country, do you have any adopt this guideline or not, or what do you think? So anyone from, can say, oh, maybe my colleague from Myanmar? Yes, do you want to share your experience on that? About the latent TB.
For the 2 drugs of the weekly study, they will be only for the isoniazid 6 months. But maybe my country have a very low coverage of the INH prophylaxis because maybe the patient's concerned. They have to be very healthy and they have to be not take to be the INH alone. They have a please clarify the TB or not. They they want to be. After that, they will be named mainly for the 70% of the patients will be the late arrival for all the symptomatic meningitis of the TB. So they have a very narrow range of the INH prophylaxis. I think maybe the very short course will be the more favorable for the latent TB treatment. This is it, I hope. There's all the clinician, they will be stayed in the reluctant enroll. So will be all the encourage for this is a TB, IPT and also the latent TB treatments. This is the state challenges. Thank you.
Okay, thank you. So any comment from Vietnam? I think Vietnam just have a very good program to eradicate TB, not just for HIV-infected patients, but for the whole country. They have the system of close contact investigation. Anyone from Vietnam want to share? No? Okay. So any country want to share on the LTBI? No, right? So, okay, So just show you the data from Trimpano study. So this is like a landmark study. So even the patient, so they have 4 groups, right? The patient with high CD4, deferred or immediate ART, and plus another whether IPT or not. So in the summary, you can see that for the early ART plus IPT, the risk of active tuberculosis is much lower than deferred ART or early ART without IPT. And when they follow up longer, they saw that not just reduce the TB, but it's also reduced risk of death by 37% from this cohort, regardless of ART. So they think that this is effect of LTBI treatment. When we look at the LTBI treatment in HIV-infected patients from this region, you can see it's not surprising because you can see that even for Thailand, no Thailand here because no any reported case from Thailand. So, and also you see Malaysia does a very good job on that. Malaysia, Philippines, and Vietnam. So, but other countries, we need to do more in terms of LTBI treatment, including for Thailand. And what's the regimen you want to use? So now we have, so the WHO recommend they add up another 2 regimens. The first is 3 HPs, isoniazid, rifapentine, okay, for adult, adolescent, and children. And another regimen is 3 isoniazid, rifampicin, for children and adolescents aged less than 15 years old. So just this morning I already speak on this. So the daily for 4 weeks isoniazid rifapentine. Just go to this slide. So why we need the new? Because of the such a lower uptake of latent TB. Even we have very strong evidence that this is good, but the issue is that why the uptake is quite low. So I think maybe because of the poor sterilizing ability of isoniazid and because of the long-term duration of a 9-month course of isoniazid and concerning about isoniazid resistance and waning adherence to IPT therapy over time. And so why we see lower uptake of IPT for many settings. So we need novel, shorter course of LTBI. So when we look at rifapentine has longer half-life and increased potency against M. tuberculosis than rifampicin. Compared to 6 to 9 months of isoniazid, 3-HP was non-inferior to isoniazid 9 months. However, so the good thing is that it had higher completion rate with 3-HP and lower rates of hepatotoxicity. You can see the 0.4% versus 2.7%. However, when we look at the Asian data, we saw such, I don't know how to say in terms of higher prevalence or higher toxicity, non-hepatotoxic, like a skin lesion and nausea, vomiting. The data from Taiwan show that the discontinuation rate is quite high in 3-HP as well. And also, just recently, in elderly from China, the study has to stop early because they cannot tolerate to the toxicity. So why I think this novel regimen is promising? Because when we look at the data, so this is a standard dose of isoniazid 300 and rifapentine waste-based regimen. So the efficacy is not different, but hepatotoxicity is reduced with this group. So I can explain why isoniazid rifapentine weekly have a higher toxicity in Asian. So maybe because of higher dose of isoniazid, as we know that about 70% of our patients, they are slow metabolizer. So maybe they have higher isoniazid concentration. So why they have higher toxicity. So I just would like to end with this slide, ending TB in 2030. So we need to complete the package. So the first one, search or find or case finding, okay, intensive case finding, and early TB treatment, and short course TB drug, and prevention, rapid ART for HIV, latent TB treatment. Another important thing is the diabetes control. So recently, we have so many diabetes patients came to our clinic with very sick of TB, large cavitation, and have high blood sugar. And also, quit smoking is also important. TB vaccine, the last one. Okay, so thank you very much for your attention.